there was a lot of interest in covering medically tailored meals and food prescriptions within the Medicaid program to improve diet-related disease. However, there were conversations about, what is the relative role of Medicaid versus SNAP and WIC in covering food. To gain perspective on how these programs and policies enable different food support, we're excited to be joined by experts from the Central Texas Food Bank and the Houston Food Bank. They will start with a brief introduction of their work, and then we'll transition to a panel-style discussion followed by Q&A. And we'll start off first with Central Texas. Bella Kirchner is here. She's the Vice President of Neighborhood Programs and Services from the Central Texas Food Bank, and I'll pull her slides up and transition to her.
Great, thank you so much. Hi, everybody. I'm Bella Kirsch. I'm the Vice President of Neighbor Programs and Services at Central Texas Food Bank. I oversee all of our health and wellness, including our food as medicine work, as well as our empowerment programs, which includes benefits enrollment assistance and workforce. But my background, I've been here about 3 years. My background's actually mostly in healthcare. So came from working at FQHC, Community Health Center, working on the private side of healthcare, doing value-based contracts with MCOs. And so just really excited to be here and talking with you all about this. Before our panel, we'll all just talk a little bit about what we're working on at Central Texas Food Bank. So you go to the next slide. Just to kind of level set in terms of, I know a lot of you have probably seen this pyramid before. Where do food banks fit into this work? For us, we really are interested in all levels here. So first is policy. We are paying close attention to what's happening at the federal level, both with food as medicine work, but also with other policies like SNAP that definitely have an impact on our work and our ability and patients' abilities to feed themselves. At the state level, Carolina will be speaking in a lot more detail about this, but we're really excited about some of the movement that's happening here in Texas around food as medicine. And then we also work very closely with local governments, so both county and city, public health departments, city councils, to ensure that we're thinking about food as medicine hyperlocally too. As we move up the pyramid in terms of nutrition security, that's kind of our bread and butter of what we do at Food Bank. So we're really getting out, making sure people have access to food. A lot of food banks are also involved in doing SNAP outreach, so helping people apply for SNAP and other government benefits like Medicaid and other programs in the state to ensure that we can, again, kind of address more long-term the need for food. And then as we move up, a lot of food banks are now getting more involved in food interventions, both food access in a healthcare setting, so just people who are food insecure, how do we get them food, but also disease targeted interventions as well. So working with health plans, working with health centers to identify patients with chronic diseases that may need special interventions, medically tailored meals or groceries, nutrition education. And so that's kind of where food banks, we fit into all levels of this pyramid. So if you go to the next slide here. So in terms of Central Texas Food Bank, who we are headquartered in Austin. We were founded in 1981, and we work with a lot of our work. We do client-facing programming, neighbor-facing programming, but a lot of work is also done through our nonprofit community partners. So we have about 250 of them across our 21 county service area. And with our direct service programs, as well as through that network of partners, we serve about 610,000 people every year. So we're able to get access to food, again, either through direct service or SNAP benefits or through our partners. Go to the next slide. We are interested, and I think, again, this is true of all food banks really, both downstream and upstream interventions. I won't spend a ton of time on this slide, but just wanted to give folks a sense of the depth and breadth of our programming. So we do programming for children, we do programming for families, older adults, lots of health and wellness programming, and then what we refer to as empowerment programming, again, to help with things like getting people connected to employment, making sure they have benefits so they can take care of their families. Go to the next slide. In terms of food as medicine at Central Texas Food Bank, I think what food banks are now thinking about is, for a long time we've worked with kind of the charitable side of, health systems, with philanthropic arms of health plans, and we really are moving to get into the business of food as medicine. So we want to move into this space as a vendor. And again, move away. Again, we've been long thought of as charity, but really want to focus on being a vendor. And so we do that through lots of different programs. And so at CTFB, the programs that we have for food as medicine, we have a big medically tailored meals program along with meal kits. And we have two different programs. One is for postpartum moms. Another program is specifically targeted to disease states. So that includes renal, heart health, GI issues, diabetes, and then just general nutrition. So making sure that we're delivering those meals to people at their homes. We also have what's pictured here, which is our mobile food pharmacy. So that allows us to go to clinics and healthcare partners on site. It's a little grocery store that folks can get on and shop. Again, for all the food on there has been vetted by a registered dietitian, and it's fresh fruits, vegetables, shelf stable, but then also we have a fridge and freezer on there that has proteins, dairy when we can get it, and we bring out nutrition education to do recipes, because again, I think another sentiment is we want to give people food, but we want to make sure they know how to cook and use it. And so we make sure to have recipes in those demonstrations. We also have a home delivery program where we, in partnership with Amazon, deliver food, both shelf stable and produce directly to people's homes. And then we couch all of this in a bunch of other wraparound services. So we're trying to, again, not just solve for today. We want to make sure that people have access to food even after they use our programs. So that's why SNAP enrollment assistance is really critical to what we do. As I mentioned, nutrition education. And then we also offer workforce training programs here at the food bank to allow people to come here for free and hopefully get trained on the job and then connected to employment so they can then pay for food themselves. One other thing about us is that we work with an extremely diverse customers and partners. So you can see them listed here, FQHCs, community health centers. We work with payers, MCOs, large health systems, mental health centers, and then even rural health nurses as well. So they don't actually have a home clinic, but we're able to take some of these interventions out to them. In addition to this food as medicine work specifically at our food bank, we're also working as a network of food banks. So our food bank, Houston Food Bank, we're all members of Feeding Texas. And so there are 20 food banks that cover every county in the state of Texas. And as you all probably guess, our service areas don't always match up to either health system or health plan service areas as well. And so what we're really trying to do is work as a network of food banks to do this work together. All the food banks have come together and said, we want to work on this together, and so that we can cover every county in the state and be able to offer some of these interventions. So really excited about that work. And, the benefit of working with us is we know patients and members really well. We've been building trust in the communities for decades. We know that that means a lot to people who are in these more vulnerable situations. If we go to the next slide. The other thing, of course, to talk about, and again, I could go on and on about this, but I'll try to be brief, is outcomes. So I think that's what everyone is interested in, is learning more about, is this, if we're going to invest all this in these interventions, do they actually make an impact? And so what we're seeing is just some examples on here of some of the outcomes that we've seen. With our mobile pharmacy project, we worked with an MCO and an FQHC. We really focused in on trying to improve clinical measures. And as you can see here, there were significant improvements in a number of really critical clinical measures here. So improvement in blood pressure rates, reduction in hemoglobin A1Cs, increase in screening rates. And so it was really great to be able to see that actual data and understand that the impact is real. So it really is helping. With our medically tailored meals and maternal health program with Ascension, we've seen that there's a 30% self-reported improvement in health by moms that are enrolled, and importantly, a 25% reduction in postpartum depression. And so again, these are just some of the data points. I can share more in chat. The other thing that we know that's critical to all of this work is also our ability to help enroll people in SNAP. So I think a lot of times when we talk about food as medicine, we don't always think about SNAP enrollment. It is critical to the work that we do, and it has a huge impact on healthcare costs. There have been lots of studies done. So for low-income adults, this is from the Center on Budget and Policy Priorities. It helps reduce healthcare costs by about $1,400 annually. There's been a correlation with decreased hospitalizations, emergency room visits, increased medication adherence. And so we really see that as a critical function to all of our food as medicine programming. I think a lot of the other food banks do as well. I'll finish with the future for us. We are really interested in research. So part of what we like to do, again, is make sure that we are doing research. And so we're working with a UT professor on the correlation between our mobile pharmacy intervention and improved mental health outcomes. We're also in talks to do some additional studies with home delivery and mental health. And so we're always looking to partner with academics, but anyone else who's really interested in this research topic. And then finally, on top of all this, we also do program evaluation. So we make sure that our neighbors are satisfied, they're getting what they need from the program. The other really interesting piece of data that we have found in doing this program evaluation is that 71% of folks who went through our mobile pharmacy intervention actually felt more connected to their clinic. So the other part of this programming is that your patients and members see this programming not as a food bank charity intervention, but as really an offering from the health system, from the health plan, and it really creates that positive association. So we're really excited to be doing this. Like I said, I could go on, but I'll pass it over to Houston because they're also doing amazing things.
Thank you, Bella. That was really comprehensive. It's amazing just the complexity of the connections that you have to make in doing this work, and really appreciate the value you placed on measurement and determining what's the effect of delivering all these services. Next up from Houston Food Bank, we have Carolina Cano and Melanie McGuire, and I'll share your slides.
Good morning, everyone. And Bella really set this up quite well. My name is Melanie McGuire. I am our Senior Director of Programs here at the Houston Food Bank and oversee all of our food prescription programs, food RX programs, as well as our education and economic mobility programs. So a little bit about Houston. The Houston Food Bank, we cover 18 counties. And within those counties, we have a network of over 1,600 partners. We are the largest food distribution food bank in the country. And through those partnerships, we also have 3 regional food banks that we support in that effort that are kind of color-coded on the map that you can see here. And really our role with those regional food banks is to strengthen both their programmatic work as well as provide logistics support in terms of food going directly into those counties. Next slide. As part of our work, we've talked specifically about, we're talking specifically about food as medicine here, but as Bella has also noted, we have several different intervention programs addressing specific populations. So for our Food RX program are really aligned to chronic disease management through nutrition-focused food and through healthcare referral programs. But we also support students and college students, as well as those that are in job training programs through a program called our Food Scholarship Program. And then for those that are users of that have high acuity needs, we provide medically tailored meal programs delivered directly to their homes. And that's really in coordination with our registered dietitians and healthcare referral providers. We also support a really robust network of what we call food for change markets. And this is really kind of that next evolution in food banking around how do we strategically align nutritious food based in community through a coordinated relationship with our growing network of partners to be able to provide immediate food access tailored to these type of program interventions. So you can see a picture of that here, and what a food for change market really looks like. What you're going to see is really a high emphasis on fruit and vegetable intake, which is roughly, the largest percentage of the food that we receive through food banks today, paired with nutrition education nudges. So really intentional moments in which we are aligning both recipes and nutrition information while patients are actually shopping for food to help them, as Bella mentioned, encourage and support the food that they are receiving. All right, next slide. So I wanted to talk about specifically how the Houston Food Bank thinks about this work as it relates to food as medicine. And what I want to call out here is specifically that this pyramid does not illustrate the intensity. It illustrates the intensity of interventions, not necessarily the importance. So foundationally, food banks operate at the base of this model, which is really the population level prevention. And we've done a lot of work in Houston to ensure that the types of food that we're receiving, how we categorize food within our systems, as you think about food banks for large logistic organizations, is categorized in such a way that it informs the community about how to be able to identify nutritious foods and how our network of partners can be able to access nutritious foods. And so that really comes around, really speaks to our healthy eating research ranking. And so all of the food that comes into the Houston Food Bank is actually ranked. And that really allows organizations to better understand that the food that they're receiving and then couple that with nutrition education information. Really, we feel that this is core to stabilization, is when people are empowered with understanding the food that they're receiving, coupled with the information and knowledge that they're able to make the best decisions for them. Then going one space above, we're really looking at care coordination and referrals. Through policy around screening and intervention, we knew there was an importance around connecting those referrals to the right programming options. And we've done a lot of work with healthcare providers as well as payers in terms of how do we streamline those workflows between screening and intervention, both building opportunities in the EMR records where healthcare providers are able to seamlessly make a referral that goes right to the Houston Food Bank. And then through a team of navigators, we're able to receive that referral and then best communicate with that patient and identify the most appropriate intervention that will fit their needs. And then one up from there, you'll see is our food as medicine interventions. And again, this is where we specifically are looking at higher acuity interventions for programs like FoodRx, where we're specifically addressing chronic disease management. This could look like diabetes or heart health needs, but also things, as Bella mentioned, like working with mental health providers. So FoodRx really aligns this through connecting with a patient, being able to provide them a unique ID that they're able to then use when they go to a redemption market. They are able to access 60 pounds of food twice a month, with over 50% of that being fruit and vegetables. And we're able to measure that those visits rates. And what we have learned through this intervention is higher utilization of visits correlates to improved outcomes, which I'll be speaking to in just a few minutes. And then finally, our medically tailored meal option, where we are specifically working with payers and healthcare providers around those interventions that are high touch, where we have individuals who have maybe the inability to cook and prepare meals on their own, in which case a medically tailored intervention for a prescribed period of time may be the best and most appropriate option. We do these interventions with over 85 locations currently, and very similar to Bella, you'll see that a lot of them center around working with both payers, large-scale healthcare systems, federally qualified clinics, across our 18 county service area. Next slide. So, everyone is interested in outcomes and wanted to share a little bit about how we measure outcomes here at the Houston Food Bank. So when individuals are enrolled into food prescription programs, we do a pre and a post survey over a 12-month period to assess where they are when they first enter the program, and then what self-reported quality of life measures they have indicated that have changed. And we're really excited about this because it really speaks to, how these programs are truly manifesting in individuals' lives. So not surprisingly, some of what we've seen through those intervention is one, an increase in fruit and vegetable intake simply by having access to larger amounts of fruits and vegetables. They're able to be able to select and receive more fruit and vegetables and incorporate them into their diet. We also saw improvements in anxiety and stress. We know that oftentimes that speaks to some of the financial trade-offs that individuals have to have, specifically when they are managing a chronic health condition. So individuals have reported improvements in their stress and well-being. And then, we've also seen increase in healthcare utilization, which was actually really surprising. We asked patients, in terms of what is the frequency in which they're using healthcare, and really looking at seeking healthcare interventions as more of a preventative measure versus a reactive measure. And so we're seeing some of this self-reported by families as well as increased food security, which is great to see, as oftentimes this is the first way that someone's connected to services is through that screening of food insecurity. On the right, you're going to see some of the outcomes that are measured by our healthcare providers. And some of these are really interesting in terms of what they're seeing on the clinical side. And so what we have seen is lower rates of A1C, reduced blood pressure, and I want to caveat this by saying, oftentimes we're seeing individuals with very high rates of A1C, and this, even just a point reduction in A1C for many of these individuals means that they're able to reduce the amount of medication that they now have to take. And so that was really highlighted as something that's really beneficial, both to the patient from a cost savings perspective, but also to their overall health. We had an opportunity to participate in a pilot with Community Health Choice, as well as UT Health, specifically on high-risk pregnancy, and aligning our FoodRx program with mothers, over 200 mothers that were identified as having high-risk pregnancy. And some of the work around maternal health has shown some really promising results in terms of improvements in overall health and well-being of newborns that were born with this population specifically. We've also seen, building trust within healthcare providers when they're able to specifically identify an intervention as a result of the screening. We're seeing higher rates of screening increase, which is really important as we want to be able to reach these individuals, not in a state of crisis, but really more as a preventative method over a period of time. Next slide. Finally, I want to talk about the importance of some of the programs that were highlighted earlier, specifically around federal benefits access and how we see these programs aligning with our food as medicine interventions. When we think about a co-enrollment, we know that this is one of the strongest strategies that we have when we think about how we improve families and household stability. And so, we've done some analysis around what it would mean for an individual to be co-enrolled in both a food prescription program as well as being able to have access to SNAP. And you can see what that impact that it has on a household's budget. We know that many of the families that are food insecure are also facing things such as household instability. They may have a difficult time paying for medication or accessing transportation. And so simply by co-enrolling individuals to both food prescription programs and federal benefit access, this has a tremendous impact on someone's overall household budget. And so part of our referral work really speaks to this in terms of when we think about food security, we are also educating healthcare providers on thinking about the importance of SNAP and how both of these programs collectively would have an impact on a patient's lives. And so through our team of navigators, when a referral is made, even for something simple as food access, we are also screening them for all federal benefit programs to identify if this patient is currently accessing federal benefits or may be co-enrolled to those programs alongside of their food prescription. I think those are all my slides. Thank you so much.
Great. Thank you, Melanie. I think for a lot of us who are not in the business, it's just impressive, just the array of different services. A food bank is not just one service. It's a whole network of services. Well, to get going on our more panel discussion, this one's for both Bella and Melanie to start out. What are some of the operational or funding challenges that you've encountered in this work of recent?
I think for us, I think it's just, making sure that there are funding paths, again, not necessarily on the philanthropic or charitable side of things, but really on the business side. And again, that's, I think, why it's really exciting to see some of the work coming through that Carolina will talk about to make sure those pathways are there. Because this work isn't free or always very cheap, but it does have a big impact. And so I think making sure people understand that. And then I think just in terms of operations, some of this work, is just really hard to do. For example, home delivery is hard to figure out. We have lots of large national companies that are also still struggling to figure that out some. So I think but we're dedicated to doing it, and we, both of our food banks do it. So I think for us, it is also figuring out that tipping point in terms of scaling. So as we scale, as we build up, what's the tipping point to invest more? So to invest more in staff, to invest more time and resources. And then also, what does that communication look like? Has to be a capacity investment as well in terms of as we start to receive referrals and things like that is work to do. So that's from our perspective, I think just things that we think about.
Yeah, I would build on that and say that in most cases, the funding that we receive as food banks are often supporting pilots and not long-term infrastructure. And really, as Bella and I've kind of shown in terms of the outcomes, to really be able to actualize some of these outcomes, it takes time. And so really being able to think more intentionally about how we fund these types of interventions that support both building the appropriate infrastructure. A lot of the opportunity areas we see as food banks is really building the connection between healthcare and food banks more intentionally. So it's a kind of a seamless transition between when someone is screened to be able to access the right intervention programs. But oftentimes the funding that we're receiving today doesn't align with those kind of needs, and so it really highlights some great opportunities for us to think more intentionally about funding, and maybe pull back on some of those areas that are very short term that are not giving us what we're looking for. I would also say that there's often an opportunity to align reporting expectations with more reimbursement areas. And so being more intentional about how we want to think about what we're reporting and how that aligns with the future direction of reimbursement would be an area that food banks would welcome. Conversation, as you've seen from some of our outcomes, we have a lot of great data about what we're seeing about how these programs are manifesting. And then I would just also echo that while we know Medicaid mechanisms exist for reimbursement, oftentimes food banks don't fall perfectly in line with those type of opportunities. And so, as we think about ways that food banks who are in communities, in zip codes across the state of Texas can more align with opportunities that can align with funding mechanisms that exist currently. We've made some really great strides on medically tailored meals in both of our food banks. But as we think about the scaling of that work, oftentimes it really takes some really great champions in communities who can help navigate that to really see where alignment between food banks and nonprofit organizations can fit into some of the policies that exist today.
Great, thank you. So policies really have a big impact. And Carolina, we're interested in your perspective. How do program rules set by the state legislature or state agencies really shape what you can do as a food bank?
Yeah, absolutely. And I'm having a little bit of camera difficulty, so I apologize ahead of time. I'll look this way. So my name is Carolina Cano, and I'm a government relations manager with the Houston Food Bank. My area is really concentrated at the state level. So I work a lot on policy and advocacy government relations at the state level for the food bank. And so, Charles, to answer your question, I mean, you heard really great things from Bella and Melanie about the on the program level, but I think what is good to note here is the policies that affect these, the legislative bills that affect the programs and the ruling. And so program rules really established by the state legislature, the state agencies play a significant role in defining both the opportunities and the limitations of what really food banks can do when it comes to programming. And so these rules primarily shape our work through eligibility requirements, benefit design, and the populations actually that the programs are intended to serve. So I mentioned eligibility requirements. It's probably the most obvious. So it really determines who can access the public benefits like Medicaid, SNAP, and also WIC. And so when eligibility is more restrictive, whether due to income thresholds, documentation that's required, and any kind of administrative barriers, many households experiencing food insecurity fall outside of the system. And so often food banks serve as that safety net for those individuals that fill the gap for people who are technically ineligible but still are in need. Also mentioned benefit design. So that also influences how effective these programs are at reducing food insecurity. For example, the SNAP benefits level, the WIC food package, or just in general Medicaid covered nutrition services determine whether households can consistently access the nutritious food or medically appropriate meals. So when benefits are insufficient or they're inflexible, food banks must apply those supports, like I mentioned, and so we become that safety net. So ultimately, state policy decisions don't just regulate the public programs, but they shape how charitable food systems like food banks operate, and then how effectively we can integrate the food assistance into broader health and anti-poverty strategies overall.
And I know from watching some of the legislative testimony, one of the questions that came up was just concerns about duplication of services, between these different programs, because they do share kind of a common set of consumers that you're assisting. So can you talk about, how these systems are complementary with one another?
Yeah, absolutely. Great question. So in practice, SNAP, WIC, and Medicaid, they're not redundant. They're designed to be complementary programs, and both Bella and Melanie talked about when you kind of stack these programs for families, they really do address the different dimensions of food and food security and health overall. So each program serves a distinct purpose. So SNAP functions as a foundational anti-hunger program. It serves the household. It provides flexible food purchasing power for households. WIC is more of a targeted like maternal and child health intervention that delivers specific nutritious food, nutrition education, and then that clinical support. While Medicaid addresses healthcare access and increasingly recognizes nutrition as part of the treatment. So through food is medicine interventions like medically tailored meals, produce prescription, these are typically more intensive and time limited. And so it's allowing participants to learn by kind of doing as they receive this food and nutrition education. From a partner perspective, we see these programs working best, like I mentioned, when they're layered together. For example, a family may use SNAP to meet general household food needs. WIC ensures that if they have an infant at home or if there's a pregnant mother, they receive the nutrition specific foods tied to health outcomes. And then when we look at Medicaid, it's, Medicaid supporting nutrition services, and that really manages that chronic disease, chronic conditions, like how Bella and Melanie mentioned, hypertension and diabetes. So not so much, rather than thinking of it as a duplication, these programs operate as a continuum of prevention and care. So again, SNAP kind of stabilizes the food access. WIC supports the early life health. And then Medicaid addresses the medical need where nutrition is part of that treatment. And when they're well aligned, they really do reduce the strain on not just food banks, but of course, the neighbors, the communities in which we serve, and in turn, improve healthcare outcomes, and ultimately reduce the healthcare costs. And so that was a lot of the education that we had to do at the state legislature last session, because there was a lot of confusion of like, well, if individuals are on SNAP, why don't they just, purchase the healthy food? And then, they saw it as more of the nutrition counseling. And so that's where HB 26 came in, Charles. And that's why the legislature believed it was best to rather have the nutrition counseling for those participating in Medicaid. And which is fine. I think that's a great stepping stone into what we want for food as medicine. But I know, hopefully later on we'll talk about the scalability of that and what we need. And Melanie did touch on that, and Bella in terms of the funding. But that was really the education that we had to do as advocates for the legislature to know the difference of these programs and what the intention is of the programs as well.
That's a great segue. So let's hear from the other panelists. What about this issue of scalability for food-based healthcare interventions? What do you see as the policy barriers or things that would help with scale?
I
Yeah.
mean,
Go ahead, Belle. I think what we've learned in a lot of our pilot work is that when we are doing pilots, we're putting a lot of resources toward that work. When we think about this in scalability, some of the key areas that we've identified is, specifically around the healthcare systems area. Every healthcare system is different. Their screening processes are different. Who gets screened is different. How the screening occurs, and when a referral is triggered is different. So while there are some information around, the importance of screening, and in some cases, the mandating of screening, really, there's a lot of variation about how these policies are actually coming into practice in terms of how intervention work is done. And so oftentimes, when we think about starting a partnership with a healthcare system or a managed care organization, we oftentimes have to understand their workflow. Where does this fit in terms of, importance to the healthcare system, how you value this work, who's getting screened, what are the key priorities within your community needs survey that you've identified that these programs are seeking to address. The other area I would say when thinking about scalability that we've in this last year put a lot of attention and resources into is data interoperability. And really what that speaks to is a lot of the work around governance, consent, how information is shared between a health system and a food bank, what information needs to be shared at what frequency, and what areas does the patient consent to this work. So even to begin thinking about a reimbursement mechanism, some of this infrastructure has to be built. And even within the same EMR system, it all operates differently. So a healthcare system could have a system like Epic, but the way that it's implemented at their location looks very different than at a different location. And so it's a lot of very intentional work with health systems and the HIE in our case as well, in terms of thinking about how the HIE and whether patients consent to information being shared with their HIE. So, I think being able to think about scale really means that we have to begin to put dollars into these areas. Even if we were to get policy to move, how these systems would operate really would depend on our ability to be able to scale intentionally and really think about the governance and consent processes along the way.
Yeah, and I'll second that. I think, food banks are not also just getting referrals from healthcare systems. We're dealing with all kinds of other incoming referrals. So I know this is something that other CBOs talk about too. And so, to ask us to use 5 different systems to manage whatever's coming in. And some of us, some food banks are sophisticated in terms of resources, technology, and others are not as sophisticated. And so I think that's also why we're really trying to think about also how we do this work as a collective of food banks as well. So to be able to think more like a clinically integrated network or ACO, where there's one entity that helps with technology, contracting, all that other stuff, and then we're kind of the service providers. And so that's really what we're working on at the state level. But in the meantime, lots of food banks do have capacity to do this work in some way. And so I think it is just a matter of kind of reaching out, figuring out, and then yes, I think when it comes down to it, as Melanie said, it costs money. So that's what it is. It's a money problem. And so if we can get more funding to help build the capacity to take in referrals, build out technology, we can do the delivery. This is what we do every day, all day, every day. We've been doing it for decades. And so it is just a matter of making sure that we have the funding to help with that capacity. And again, your Medicaid member, your patient is our neighbor. And so it's the same person moving through the system. It's just we've got to get the system connected. And, in Texas, because we have a federated HIE system, Houston looks very different than Austin, looks very different than San Antonio, looks very different than Dallas. And so we have to think about the reality of the technology as it is locally, as well.
Great,
I would
thank you.
also just add, I think really food banks, as Bella mentioned, have evolved quite a bit. And so being able to understand that food banks are not just community partners in this relationships, but really have an opportunity for implementation of programs at scale is really important in this discussion as we move forward. Oftentimes, the ability to include a food bank in those strategic conversations as we think about scalability of this work is not first top of mind, but oftentimes, as Bella has mentioned, through our work, I mean, through disaster response, COVID, we're really well positioned to be thinking about how we can do this work in zip codes where we may not have a healthcare entity, but we have a high prevalence of individuals who are needing work or who are needing services. So really thinking about that on the onset and not maybe farther down the road would be really important consideration as we continue to build scalability.
Well, this has been a great discussion. It's generated a lot of questions in the chat. I'm going to select out a couple of them and just throw them out. So Cassidy Penn asked, from the managed care organization perspective, what can the health plans do to start taking steps to work with food banks on medically tailored meals and food RX?
I think email us. So again, as Melanie said, some of us are very far down the road already on this path. And so, as I mentioned, depending on where your MCO or health system is, it may be better to work with an individual food bank. So, for example, if an MCO or health system is just within Central Texas Food Banks area, work with us. However, if your service area is large, wide, varied, as I mentioned, as food banks, we're working together on making sure we can deliver on this work. So we can help assess what your needs are. And I think that, it points to what Melanie just said. We're really good at being thought partners with you all on how to help solve these problems because we've been doing it for a while. And, some of us have been in healthcare, have worked with healthcare for a really long time. And so that knowledge really is there. I think we're also interested in making sure that we're also showing you all value. So that's why we think about outcomes. That's why we think about program evaluation, is that we also want to thought partner with you all, so that you can make sure you're showing who you're having to answer to that this is a valuable program that's meaningful and has an impact on your patient population.
All right, Cassidy, you got that? Can send an email. I mean, a lot of these big systems that we're talking about, it really does come down to personal connections and partnerships. And that way, y'all can connect and meet you where you are. Lori Long had a question about just the frequency of delivery of food packages and how that kind of plays into the metrics about outcomes that you were talking about.
Yeah, I think I mentioned in my presentation, but from the Houston perspective, we have a very prescribed program for our healthcare interventions, and it's been studied, which is why we've kind of looked at that prescriptive model, which is twice a month, 60 pounds. You'll see 50% of that be fruit and vegetables, which is also how we are able to equate the economic value of those food that's going to our neighbors. And the reason we do it specifically twice a month, although in some cases we may have neighbors accessing who can't maybe take 60 pounds or accessing it on a weekly basis, is that, the charitable food model specifically looks at generally folks accessing services once a month. We know that SNAP is not, is a supplementary program and not able to meet everyone's immediate needs. And so when we looked at and studied specifically the frequency rate, where we began to see higher rates of fruit and vegetable intakes, improve health outcomes, was through that model of twice a month access. And so we do a lot of work with our neighbors to be able to communicate with them if we're seeing lapse in their visit rates, and directly texting folks if they haven't redeemed their benefits, to really encourage using these programs at a higher frequency, which seems counterintuitive to the emergency food system model, but really speaks to improved health and well-being.
And William Lyons had a question about the Amazon delivery. Have we figured out a funding model that sustains that, or is this more of a pilot or a grant kind of mechanism?
Yeah, so Amazon, we've been working with them since 2021. And so they've actually donated delivery services in kind to us, and have promised another 3 years at a minimum. And so for that, in terms of the actual food, so we have delivery covered. In terms of staffing and food, that is covered by both grant funding from public health sources, as well as contracts with actual providers as well. And again, we're working with researchers on this initiative as well to study the impact of home delivery, for patients too.
And I know in preparing for this webinar, we talked about how data exchange and data sharing is like a whole other topic, and we could have a whole webinar on that. So I'll acknowledge we've got a couple questions in the chat. We won't elevate them all here, but maybe just one from Jacqueline May. She's just talking about how do you set up like this referrals from the healthcare providers and then sharing back to their diagnostic outcomes so they can kind of close the loop on their end. Any brief comments you want to get into without opening a whole can of worms?
Yeah, for us, because I know, again, Houston Food Bank has invest a lot in technology. For us, we currently use whatever referral system our healthcare partner uses. Again, they are paying for us to do this work. And so we're able to basically purchase capacity, make sure we have staffing levels that are up. So that includes Find Help. In some cases, it's old fashioned and we're still just have a secure link to an Excel spreadsheet. And then, but yeah, always trying to think of new ways to connect. Again, the technology is just very diverse around the state. So our case management platform is not as sophisticated technologically as the one that Houston Food Bank does. So it's a little hard to do the integration. But yeah, we use currently mostly the Find Help platform because that's what the health systems or MCO are using.
Yeah, and for Houston, on the referral side, we use two different kind of systems for healthcare providers that integrate directly with the HIE. We are in the pilot phase of scaling a direct connection through the EMR to the food bank. We have a whole webinar on the Care Network that talks about how this process occurs. But we're really excited about that because it really allows both the healthcare provider and food banks to stay in their systems of record. And then for those that do not interface in that space, we offer a direct link through, I think someone mentioned it in the chat, through another external vendor that allows individuals to click for healthcare providers or managed care organizations to use that direct link to create a referral. And then our team of navigators can retrieve that referral from that direct link, connect with patient, and then provide information back to either the managed care organization or a healthcare entity.
Great, thanks for that. I know everybody is interested in getting that data and understanding the flow of data, so we might have a repeat engagement to discuss more on that topic. We've had a number of really good questions from both managed care and hospitals, but on registration, we had a question about local mental health authorities. Is there anything you want to say about kind of the unique way of working between food banks and local mental health?
Yeah, we work very closely with the one in Travis County and are looking to partner with more. I think that, again, trying to bring food to where patients are is really important. So we try to do that as much as possible. One other intervention that I didn't mention or maybe skipped over is healthcare, on-site healthcare pantries as well. So we're also working very closely, providing technical assistance for healthcare entities that are interested in setting up pantries. So our mental health authority here in Travis County has an on-site pantry, and then we also work with them taking the mobile pharmacy out. So really, again, trying to provide that kind of whole person care where a patient is, if possible. But yes, what we're finding in these preliminary, in our research with the UT professor around correlation between interventions and mental health, obviously not super surprising, is that when people have access to food, then they have lower stress levels, lower anxiety levels. And so, yeah, we think it's critical. And so, again, we think of you all as a healthcare partner. If you have interest in working with us, reach out to us. We can figure it out. Because again, it's really important for that mental health piece too.
Yeah, I would echo what Bella said. I know Dr. Williams is on this webinar, who could speak specifically to how partnerships with FoodRx and mental health have impacted directly the population that he works with and serves. So I think there's great learnings. I will also just say, while we didn't get into a lot of the data and stats specifically on the health outcomes, both Bella and I are happy to share that information. But what we saw around stress and anxiety post FoodRx intervention was a 63% decrease, which was incredible. And so, specifically working with organizations that address mental health are great opportunities, but we also understand that mental health underlying issues may be occurring in patients who are not necessarily been even diagnosed with mental health, which can lead to, concerns around medication adherence. It can lead to areas of social isolation and other outcomes. And so just being able to see patients report, specifically great improvements in stress and anxiety also speaks to the fact that sometimes these interventions can also support other areas that patients may not disclose to their healthcare provider.
Well, this has been a lively discussion. I really appreciate you all kind of sharing the nuance and complexity of doing this vital work for our communities.